what are we talking about when we're talking about public health palliative care? By the end of tonight, or my talk tonight, what I'd like you to be able to have a clearer idea of is just what palliative care is, and how palliative care is not just about managing suffering, but it's about promoting health and keeping people healthy even in the face of life-limiting illness. And palliative care has changed an awful lot over the last 50 years since it started off. I've been doing it now for 35 years, and I've seen an awful lot of changes. It's resulting in a lot of, we can do some wonderful things that can really help people to preserve their quality of life, right, hopefully to the last breath. But it's adding a lot of burden on our healthcare system if we don't find better ways of doing this. So I want to talk to you about a way that we can use a public health approach to bring palliative care and hopefully all of our healthcare into the 21st century when it comes to helping us to stay healthy right to the end of living. So when you hear the word palliative care, this is the kind of scenario that you might be thinking about. You know, it's hard. It's really hard to think about palliative care. It's the compassionate thing to do. We have to take care of each other as we die, but it's around all the hope is gone. We know that it's the end for us or the person that we love, and we just hope that we can manage the suffering, reduce the burden, be able to make sure that we live where we want to, and be supported without burdening the people that we love. And, so people don't want to think about this, and often we're all accused of being a death-averse society. And we certainly are not used to and as comfortable with having people reach the end of our lives in our society today as our grandparents were when they were younger, because we don't see the same kind of patterns of people approaching end of life. For most of human history, those two top graphs are the way that most people died until very recently in our human history. Of course, there's sudden death. There was a lot of trauma, lots of accidents, a lot of sudden onset of infection and other things that led to a very rapid or sometimes immediate demise. The other one is the terminal illness trajectory. And virtually any serious illness in human history was a terminal illness. This graph here kind of displays what was the classical cancer illness trajectory. And so when you were diagnosed with a cancer, you were functioning pretty well despite that diagnosis for quite some time. And then when the cancer really started making you sick, then the decline was pretty rapid. So palliative care was born out of cancer care. In the 1960s, it was a response to being able to say, we cannot just tell people with terminal illness like cancer that there's nothing we can do. We have to be able to make sure that we can manage symptoms, improve the quality of living, not just for the person that's going through the illness trajectory, but for the people that love them and all the people that suffer because of that. So palliative care evolved into an aspect of healthcare that was very much around a compassionate approach to dealing with pain and symptoms, to making sure that caregivers weren't burnt out. And so usually palliative care was thought about as a place, a hospice or a hospital where you had to go to get that kind of care at the end of life. And this illness trajectory would be measured in days sometimes, maybe weeks, but not very long. So what has happened in the last 35 years in my practice is that we've had all of these huge advances in health care that have allowed us to really be effective in addressing the illness trajectories to a degree that we've never been able to do before. We are all familiar with things that we couldn't treat 35 years ago. Cancer care has now become a chronic disease and not this kind of terminal disease for the majority of people living with it. And the chronic illness trajectory is that organ failure graph that you see below. And cancer and other diseases usually result in very long-term issues around health and addressing the suffering by treating the disease, trying to minimize the impact that it has. It's a fluctuating course that relapses and remits, so people do well sometimes, need a lot more help other times, and it goes over months, maybe even years. And more of us are getting even past that, where we don't have any significant organ failure or cancer until we get to a very old age, and then we start to see the degenerative changes. And so more and more of us are following that frailty illness trajectory, where by the time you're even diagnosed, you've had a really quite dramatic disruption in the way that you can care for yourself, and you've relied very much on others, and then you have this gradually dwindling course over a long period of time. So now we talk about palliative care from the onset of the disease all the way through to the end of living as palliative care. It can go on for years. And the model that we had before of weeks to months of care will not work if we're relying on health services. So what we have to do is to start looking at this new kind of concept of what palliative care is. It's not about just lying around waiting to die, giving up, and there's no more hope, and I'm glad I'm not in pain. It's about living until we die. That is very much of a problem for us now, because we cannot have the services that are going to provide the care that we need just in health services. It will burn us out. There's a researcher by the name of Alan Kelly here, who is a sociologist, originally from Australia, now in England, who started writing in the 90s about public health approach to palliative care for this very reason. People have to not only have their symptoms managed and their quality of life managed, they have to be with us, living in the community as they go through this illness. What's the use of being able to control a disease if it can't get you back to life worth living? So Dr. Kelleher and others started talking about this palliative or public health approach and health promoting palliative care or compassionate communities. So when we talk about health promoting palliative care, we're talking about improving the health and wellness, well-being in the face of life-limiting illness, not just for us, but for not just for the person that's living with the disease, but for everybody that is affected and suffers because one of us has a life-limiting illness. So the individuals, the people that love that person, and all of us who are in that community, we all suffer, and we need to be able to address that collectively. Things like loneliness and isolation that come from living with a life-limiting illness and being set apart from the rest of us is not something that we're going to be able to deal with healthcare. I tell my students that when I'm approaching the end of my life, if there's somebody from the health services that can be around to make sure that my family is supported so that they can help me to be able to get through my daily routine, get cleaned up, and get ready for bed at night, that's great. But I don't want somebody from the health services tucking me in at night and kissing me and telling me they love me. That is my family. That's my community that has to respond to be able to make sure that life was worth living. And so this is what the focus is when we're talking about health promoting palliative care. And this is the concept that we're talking about when we talk about compassionate communities, because this is something that has to be worked to develop. One of my earlier experiences with this kind of development of a compassionate community was in 2010 when I was asked to assist a non-governmental organization in northern Burkina Faso to be able to help them with their response to people living with HIV in their community. And I see a few lights and a few Google Earths going on their phones over there saying, where's Burkina Faso? Go ahead and look it up. I had to look it up too. It's in Western Africa. It's one of the poorest countries in the world. Median income, at the time that I was there, was $1.42 a day in US dollars. It hasn't changed much. This country was 187 out of 193 in the UN Development Index. The only countries that were poorer than Burkina Faso were conflict countries. This is not a conflict country, but they're extremely limited in resources. The agriculture is probably their main employer, but the main source of foreign income is through migrant workers that go to neighboring countries. The NGO that I was working with had developed an HIV clinic, and this clinic was developed in 2008 or 2007 in order to address how to be able to help people living with HIV in the community in the absence of any medical treatment. Burkina Faso at the time had 1,100 doctors and just over 5,000 nurses for 17 million people. There is virtually no health care there. And so they were trying to be able to find ways to support people in the community by identifying and doing voluntary testing for HIV. And they had rapid tests that they could use, and then they had access to confirmatory tests afterwards. But also to provide counseling and support for people who were being stigmatized in the community. Once you had HIV, you were excluded from the community. Your family excluded you. From an economic perspective, somebody who was going to follow an AIDS illness trajectory was going to burn out the family and not be able to, and it would just drain everybody's resources. So the answer was to just set people apart. And so this NGO responded by developing this, bringing people in, seeing how they're doing, got to see a nurse. They got together as a group and they would help to support each other, and they would talk about their experiences. The older people, and this was almost all women and children at the time, a few men, but not many. And so the older women in the group would be the grandmothers who would prepare a meal for everybody. And they would do this on a once-a-month basis. And then when they did finally get some of the very older HIV medicines that we had already had for 10 years and weren't using much anymore and that were less expensive, then they were starting to actually be able to take care of some of these people with medications, and they were very resourceful in making these things work, and it was making a big difference. So when they asked me to come and help with their HIV palliative care, of course I get there and I see this and my heart stops. How are we going to be able to help them to develop their capacity to address suffering? So when I met these people and I saw what they were doing, I was able to sit down with the people who were running the NGO, taught them what palliative care was, and showed them that they were doing palliative care and what they were doing and how effective that was. This was a clinic that addressed the needs for people who were in the area of Yako, which is a city of about 40,000 people. But most of the people in northern Burkina Faso live in very scattered communities of 100 and 200 people. And I asked, what's it like for those people living with HIV in those remote communities? The people from the NGO said, we don't know. And so we thought about how we could find out. And the answer was they are creating communities for people who had no communities anymore because of HIV. So what we did was we developed a program for development of peer counselors. And we brought the stars from these groups, the people that were doing really well, taking their medications, following up regularly, supporting each other. We found funding for $25 a month to pay them, which is more than the average income for people in Burkina Faso, and it was enough money to live on. We sent them through the training program. We gave them single gear bikes so that they wouldn't break down and they could be easily managed. And we said to them, you just go out and find out what it's like to be with people in the community who are living with HIV in the remote communities. 2 years later, I come back. These people were getting together once a month, and I got to see one of their meetings. They were seeing 100, 125 people a month. They would come together and bring in their data for the international funders. They would talk about their challenges and their successes and their problems. And this one woman in the middle, who was in a taupe kind of dress, said to me, we have become the light of hope for people living with HIV in our communities. And this is what we mean when we're talking about a community's capacity and a compassionate community. there was virtually no healthcare response. That little girl in the front of the row of there that you see was the first child that was born from an HIV-infected mother that didn't have HIV, and she was a celebration. She was a miracle. But they were doing miracles every day. So what do they have that we can learn from to be able to help bring our palliative care into the 21st century? They're connected as a community. And there's been a lot of research, and I've been involved with research looking at how communities decide to address the issue of keeping people as part of their community and not having to move away from rural communities when they're living with life-limiting illness. And there's no lack of leadership in these communities. People come together and say, we have to do something to keep from sending our people off to the horrible place called the big city. We have to be able to keep them as part of us in the community. So they come together and they get a charter and they get their charitable donation status so that they can accept donations. And then they work to be able to increase awareness in the community, and they work to go to health services and advocate for services for that community. The problem is that these leaders tend to not really be well connected with the needs of the communities and understanding it. And health services, when you go and say, we want more health services, the reaction is we're not going to be able to put a hospice in every community. And it just doesn't work. And it ends up being adversarial. And most of these local hospice societies end up just running out of energy and then withering on the vine. And so we wanted to be able to look at how can we nurture that connectivity in the communities. For a long time, that the more the connectivity there is in the community, the more social capital there is. And social capital is a way it's just a value the community has. It's not a financial benefit, but it is of economic value to the communities, and the communities can spend it and use that to improve the community capacity. So just like these people in Burkina Faso were coming together and improving their capacity by just coming together with some very limited infrastructure, we can be able to do that now. But what we're finding is that connections within the community itself are not enough to generate enough social capital to overcome some of these barriers, to be able to understand what palliative care is, what communities can do, and to learn about the individual communities themselves and their challenges and their strengths, and be able to adapt their approach to that specific community. So what we've been trying to do now is to be able to develop a mechanism where we can bring communities together into equal power-sharing relationships with policymakers and governments, with health services, and to be able to understand at the level of the people that are experiencing life-limiting illness and the people that are caring for them, what their needs and what their strengths are, and being able to do that. We've been doing this in a prototype way now, and we've started with rural communities around the city, and brought them together, to help these societies be able to get a better understanding of what their strengths are in the communities, and it's brought the communities together. And now the communities have taken the lead on this, are forming associations of rural hospice societies, and have a direct relationship that is much more effective and much more positive with the health services in the health region. This is the approach that we think is going to allow us to be able to move into the 21st century, care for people right from the time of the onset of illness through to the end of life, and address the suffering not just for that individual, but everybody that's suffering. So my message to you today is you came to hear about the future of health. The future of health is you. We need everybody to be able to participate in this. Think about how many communities you belong to and how you can be able to work in those settings to be able to promote these kinds of things, not just for palliative care, but for many other things that we need to develop a community response to now that we've been able to modify the diseases and the illnesses as much. The focus has to always be on health and being healthy even in the face of the disease. Thank you very much.